Okay, so the next portion of the discussion is immunization approaches in patients with hematologic malignancies. And so our presenter will be our guest speaker, Dr. Victoria Hall. Dr. Victoria Hall is an infectious disease specialist based at the University Health Network, UHN, in Toronto, particularly at the Toronto General Hospital. Originally from Australia, Dr. Hall completed her medical education at the University of Melbourne and pursued postgraduate training in infectious disease at the University of Toronto. She brings extensive experience in managing respiratory viruses and developing vaccination strategies for cancer patients where infection prevention is critical to patient outcomes. And Dr. Hall has her conflict of interest on the slide there. And so with this session, the objective includes the following: review current immunization recommendations for patients with hematologic malignancies, discuss the timing and types of vaccines appropriate for these patients, and manage challenges and considerations in immunizing immunocompromised patients. And so we're going to do a quick clinical case check-in. And so Richard is now 6 months into his CAR T-cell therapy, and he has an appointment with his physician to discuss infection risks and vaccinations. Questions include: what vaccinations are recommended after cellular therapy? What are the considerations for live versus inactivated vaccines in this patient? And so these are things that come up often, even in the outpatient malignant clinic. And so I'll invite Dr. Hall to the stage.
Thank you. Thanks for the introduction and for letting everyone know I'm from Australia, so that's where the accent is from. Hopefully you can all hear me all right. Oh, okay, so there's a bit of a delay. So there's the learning objectives, the clinical case check-in, so I'll come back to this kind of during the slides. But firstly, to start off with, why are we discussing this and why is it important? So in post-cellular therapy vaccination recommendations, it is important because, as speakers have alluded to, infection does remain a significant cause of morbidity and mortality among patients with hematological malignancy. And this does include those experiencing enduring remission after transplant or cellular therapies. And so vaccination strategy really represents a pillar of supportive care that can help augment protection against infection. I mean, they've come so far, why stop now? We need to kind of support them in their remission stage or even in their active hematologic malignancy stage. Vaccine preventable infections can include late viral reactivations such as VZV, or can even be due to overwhelming sepsis due to Streptococcus pneumoniae or Haemophilus influenzae. And the COVID-19 pandemic really demonstrated how hematologic malignancy patients are disproportionately affected by infectious diseases that early on in the pandemic really lacked adequate prevention strategies. You might remember caring for patients with heme malignancies who had COVID-19 in 2020, early 2021, before vaccination and antivirals were kind of widely available and recommended. Their mortality was up to 50 to 60% in some series. The clinical relevance of reduced antibody titers is something that we get asked about and is broached about in the literature. This is really poorly understood, and I think it's important to remember that it's really only one kind of tenet of their immune response. We don't really have great literature about immune correlates of protection for any of these vaccine preventable infections. And there's also other parts of the immune system that can be just as important. For example, cell-mediated immunity that can protect against severe disease, not just acquiring infection. So I'll start off with vaccination in hematopoietic cell therapy recipients, because this is actually really where most of the data is. We have a lot more experience in the literature and clinically, and a lot of the vaccination recommendations are actually extrapolated from, in particular, allogeneic hematopoietic cell therapy recipients. So regardless of pre-transplant donor or recipient vaccinations, HCT recipients may lose their immunity to various pathogens if the recipient is not revaccinated. So we do recommend at this stage to consider them as never vaccinated and requiring a full revaccination schedule, really following, for example, a childhood immunization schedule, and also considering age, country, and epidemiology. So if you look at the literature, there's many kind of guidelines that are available, and these do vary from country to country, and that's really why. It does usually commence at 3 to 6 months post-transplant. Some of the respiratory virus vaccines can be given earlier. It really depends on the timing of their transplant, and if there's a kind of epidemic of influenza, for example, you might want to do it earlier. This does differ between centres, and there are some approaches where people will defer vaccinations to commence at 12 months if there's potential for delayed immune reconstitution or negative impact of therapy, for example, anti-CD20 therapy. In the literature, some will suggest to delay as per a certain CD4 or CD8 T cell count. There really isn't a specific number that tells us how patients will respond to the vaccination, and we do need to acknowledge that if you're deferring vaccination, then you are actually going to be delaying that protection. So we know that inactivated vaccines, so this is not live, are safe after transplant. The only downside is that their immunogenicity may be reduced, but there is improvement over time and an expected response for patients that are doing well and in remission at 2 to 3 years post-transplant. So really what you would expect from a healthy population. Patients with GVHD, however, are at high risk of infection, and they therefore benefit the most from vaccination. However, the downside is that their vaccine response may be impaired due to immunosuppression. So this is something to take into account for those patients, and also think about maybe they have a higher risk of infection despite the vaccinations that they've received, and what prophylaxis they might benefit from. Live attenuated vaccines for allogeneic cell transplant recipients are only recommended in specific circumstances and in at least 24 months post-transplantation. And this is due to the risk of vaccine-transmitted disease. The optimal vaccination of household contacts is also something that we often kind of overlook, but it's definitely encouraged. This is the people that your patient will have, most contact with. So if they're protected, it's much less likely that they will acquire kind of vaccine-preventable infections, or that they won't bring them home. So the live measles, mumps, rubella vaccine, varicella zoster virus vaccine, for example, are safe to have given to the household contact. For other vaccines, they're not particularly common, but intranasal live attenuated influenza vaccine or the oral polio vaccine are not recommended if there's an immunocompromised person in the house. So I'll give an example schedule for a post-allogeneic cell transplant recipient. A lot of the kind of schedules and what is in the literature predated COVID-19. So at the moment, the recommendations are still for a primary course of revaccination with 3 doses of COVID-19 vaccine. This can commence at 3 to 6 months post-transplant. The mRNA vaccines are preferred, there's a greater available evidence for their efficacy and safety in immunocompromised patients. And ongoing vaccination, I have left a kind of generic sentence because it always changes. This is as guided by Health Canada and NACI. So currently, there will be an updated variant vaccine available for fall, which is the JN1 and KP.2 containing vaccines, and they're expected to be authorized in time for the kind of fall immunization campaigns. For RSV, this is the new kid on the block for us. This is incredibly exciting because RSV can cause very severe infection, in particular in allogeneic cell transplant recipients. If they get RSV in the first 100 days post-transplant, their mortality is up to 70%. So this is one dose at 3 to 6 months post-transplant, and licensed for 60 years or old. This may change. There have been studies that have been performed in the solid organ transplant recipients in adults above 18. So I guess watch this space for whether that age recommendation changes. At the moment, there's no evidence for boosters or repeat doses. So this is just a kind of example schedule for allogeneic cell transplant recipients. And then a lot of centers will also extrapolate from this for their CAR T-cell therapy recipients and their autologous cell transplant recipients as well. As I mentioned, I think when you look at how much data we have, the allogeneic cell transplant recipient literature is really the gold standard, and then we go from there for the other cellular therapy patients, although we do need to acknowledge that they are incredibly different with their immunosuppression and their expected immune reconstitution. So I think we do have a lot of work to do to improve and personalize these vaccine schedules. So first up is Prevnar 20. So this is a conjugated pneumococcal vaccine that's really replaced PCV 13 or Prevnar 13. This would be recommended, but of course, if PCV 13 is available and funded, then that is fine as well. At the 12-month mark, you would give PPSV 23, so that you are able to get more strains of pneumococcus. That's kind of what PCV 20 gives an advantage to now, that they have a greater number of pneumococcal strains, but that it's also conjugated, so it means a better immune response. And then the next vaccines are meningococcal, so MenACWY and MenB, and then the higher dose hepatitis B vaccine. So this is 40 micrograms. If you only have 20 microgram available, you can give 2 doses, but the higher dose is recommended. And then checking serology kind of 4 to 8 weeks post the 3rd dose, aiming for it to be above 10, which we do think is protective. If not, then they can be considered for further doses after that. Then the DTaP IPV Hib, which is your tetanus, diphtheria, pertussis, inactivated polio, and Haemophilus all together. If you don't have that, which is PDSL, you can have the 2 different separate formulations. That's fine as well. For some patients who are under 45, the HPV vaccine is funded and indicated. The live vaccines, so varicella zoster virus and MMR, I'll talk about in later slides. We do now have Shingrix, which is a recombinant inactivated herpes zoster virus vaccine. This is recommended starting, it varies, at least 6 to 12 months post-transplant. And this is really meant to reduce the incidence of shingles occurring post-transplant. So it's not meant to replace a kind of primary chickenpox vaccine. There has been some controversy about that amongst clinicians and transplant centres. The influenza vaccine, there is good evidence that a second dose will be beneficial. In stem cell transplant recipients, this can be given a month after the first. And there's also been some recent evidence from some American centers that the high dose vaccine offers better seroprotection than the standard dose. So what about vaccination post-CAR T cell therapy? I know it's taken a while to get to this, but as I mentioned, there really is less known about the burden of vaccine preventable infections in these patients and the role of revaccination. As mentioned, they unfortunately have prolonged B-cell aplasia, loss of memory B cells, hypogammaglobulinemia, and this may impair humoral protection against various infections and vaccine preventable infections as well. So few studies have really systematically explored the persistence of pathogen-specific IgGs after CAR T. They often differ in the timing of their measurement, exclusion or inclusion of patients receiving IVIG. This can actually affect when we measure antibodies because we're measuring what is contained in the IVIG and not really from the patient. There's mixed populations and in some series, a lack of BCMA treated patients. And does the CAR T target influence antibody retention and production? Theoretically speaking, the CD19 positive product will deplete CD19 positive memory and plasma cells, but there is a CD19 negative population that's able to replenish and produce antibodies when encountering previously encountered antigens, whereas the BCMA products will deplete all BCMA positive plasma cells, and this may be associated with lower antibody positivity. The predictors of vaccine immune response largely are derived from COVID-19 vaccine studies, so we do have COVID to thank for that. Really expedited kind of our knowledge in this area. So steroid use and non-Hodgkin lymphoma predict poor vaccine response, potentially related to kind of their lingering immunosuppression before receiving the CAR T, and a high number of circulating B cells, not unsurprisingly, is predictive of vaccine response. I think we have a lot of work to do though. To date, there's only 2 other studies that have examined immune response and vaccine response out of COVID-19, one for pneumococcal and one for influenza. I don't think we can draw that many conclusions from either of them. They were small studies, as I've mentioned, mixed populations, and a lot of patients had also had IVIG. So this is an example schedule that's available in the literature for post-CAR T cell therapy. I think it includes most things and gives a reasonable timing for when to revaccinate. What's missing is Haemophilus. We are giving that at UHN at 6 months post-transplant, just 1 dose. As I mentioned, the PCV13 can probably now be replaced by PCV20 if available. The influenza dosing is also up for debate. Some centers will give 2 doses as they do in allogeneic stem cell transplant recipients. So this is a paper I'll touch on quickly that I did during my PhD. It's really just to highlight what I mentioned before, that I think we have a lot of work to do with trying to figure out the best schedules in non-allogeneic cell transplant recipients. So we looked at early seroprotection and seroconversion to some of the common vaccine preventable infections and the vaccines that we give at 6 months. And our results were actually quite pleasing. So after 1 dose of tetanus toxoid and Haemophilus, around 70 to 90% of our population achieved seroprotection. We do, at the center I was at, usually give 3 doses of these vaccines. So perhaps we don't have to in all, and maybe there is a role for antibody testing in these patients. Pneumococcus was much lower, and I think that supports what we do currently, which is give the 3 doses. The other thing that was nice to see was that they tend to hold on to their live virus vaccine immunity. So in particular, VZV, measles, mumps, rubella, this is much higher than what we see in the allogeneic cell transplant recipients, which is in the range of 30 to 40%. So again, I think there's scope for us to be able to kind of individualize these schedules. Moving on to priority vaccines before immunosuppression. So what can we think about before we kind of launch into active therapy? Usually there's not a lot of time, but if we did have time, then live virus vaccines at least 1 month before, and all the kind of necessary inactivated vaccines aiming for at least 2 weeks before, so that they can get some sort of immune response. These are the kind of major ones. And other than the live virus vaccines, these are probably also the priority vaccines to optimize in patients who are receiving active therapy. And then what about live vaccines in immunocompromised? So generally they're contraindicated, and patients do unfortunately receive these. We have to kind of promptly assess them, assess their level of immunocompromise, and decide whether they should receive immunoglobulin or antiviral as appropriate. These are some of the examples, including BCG vaccine. So this is always contraindicated. And then if there is an inactivated version, then we really should be looking at giving that, not the live virus vaccine version. These are some other of the live virus vaccines, just to highlight that Zostavax should no longer be available or recommended, and this is really replaced by Shingrix. So if they're severely immunocompromised, the kind of general rule is no live virus vaccines. Once they have finished their therapy and they have immune reconstituted, I think it's up for discussion about suitability and whether they need it. What about the Mpox vaccine? So this is called Imvamune. So Mpox is a viral zoonotic disease that can cause severe illness in immunocompromised patients. But this is actually a live attenuated replicant deficient vaccine. At the moment, it is available for primary preventative vaccination for groups at risk of exposure, and there are kind of 5 or 6 categories that the Department of Public Health lay out for who would be appropriate. And there's also post-exposure preventative vaccine. So this is for anyone categorized by public health as a high-risk contact within the past 14 days if they have not received 2 doses of pre-exposure vaccination. Patients with Mpox infection are not recommended to receive the Mpox vaccine. And individuals are eligible even if they have received the smallpox vaccine in the past. So these will tend to be older patients when it was available. The recommended schedule is 2 doses subcutaneously, 4 weeks apart. And the evidence is limited, but the immune response is likely to be reduced in people who are severely immunocompromised. So perhaps they'd benefit from additional doses for those at ongoing risk of exposure. They have had some small studies already that show that the vaccine effectiveness is slightly reduced compared to immunocompetent persons, but it does appear to be safe, which is great to know, including in hematopoietic cell therapy recipients. And what about serology before vaccinations? So these are the kind of recommended ones. So measles, mumps, rubella, varicella zoster, and others to help guide whether they should have revaccination or, for example, travel for hepatitis A IgG. For MMR, this is kind of general guidance. So patients are considered measles immune if they have some of these categories, but if they're post-hematopoietic cell transplant, then the vaccine is recommended at 24 months or greater, they have to be seronegative and then considered immunocompetent. So no GVHD, no immunosuppression for over 12 months, no relapse of their underlying disease, and also no recent IVIG. Shingrix versus the live attenuated varicella vaccine. My center has received a lot of attention, and I think that's because there kind of appears to be a lot of heterogeneity in practice, including in guidelines. So who should receive it? When is the optimal timing? When antiviral prophylaxis should be discontinued in the setting of Shingrix? And who should be receiving the live attenuated varicella vaccine? So this is a proposed schedule that we kind of agreed upon around 4 weeks ago at the allo transplant meeting. It is small text, so I'll talk through it. So basically, we're performing a VZV IgG for all allo transplant candidates before transplant. If it's positive or negative, but they have a clear history of chickenpox, which most patients will remember, or they have 2 documented doses of live attenuated varicella vaccine, which the younger patients may have had, probably under 25 years old, then at 12 months or more post-transplant, we are providing Shingrix and then discontinuing valacyclovir a month after the second dose. In the patients who have a negative varicella before transplant, no history of prior chickenpox, and no history of the live attenuated varicella vaccine, there was kind of consensus that we should still be offering them Shingrix because there may be some immunity protection from it. But afterwards, at 24 months post-transplant, kind of reverting back to the guideline recommendation, which is to check the VZV IgG. If it's negative and safe, then giving the live attenuated varicella vaccine. So how can we improve immune responses? I guess quite a general question, but I think some of these are the strategies. So thinking about the optimal timing from immunosuppression, time from IVIG for live vaccines, for example, whether the patient would benefit from additional doses. We've seen this with COVID-19 and also influenza. If it could be augmented, or they should receive a high-dose vaccine formulation, for example, with influenza or hepatitis B. And what we saw with Evusheld, perhaps something that still works, but giving a monoclonal antibody, coinciding with their cellular therapy, acting as a bridge to immune reconstitution, and then allowing us to delay vaccination for kind of 3 to 6 months. Antibody testing after vaccination is not generally recommended. As I've touched on, it's really just one kind of aspect of their immune response, and we don't have a lot of literature about what is considered seroprotective. The 2 that are useful are hepatitis B and MMR, so this can guide whether they need a second dose of the measles, mumps, rubella vaccine. And then lastly, discussion with patient on vaccines and costs. So I think it's important to have this open discussion as you do about their heme malignancy and the costs that come with that. Kind of laying out, I think, what is best practice and guideline directed care, being upfront and informing them of the expected costs, and understanding if they can't fulfill all recommendations, then what can we prioritize? And I think ongoing advocacy to include them in research so that we are able to really individualize these revaccination schedules, which potentially can reduce their outpatient care burden and also needle burden. So finally, vaccines do form an important part of supportive care for patients with heme malignancies, including post-cellular therapy. Inactivated vaccines are safe, but their immunogenicity might be impaired. Live virus vaccine administration, as mentioned, is really dependent on the timing post-therapy and their immunocompetence. and advocating for them to continue to be assessed in research and clinical trials so that our knowledge is kind of best informed about their immune response. So I'll stop there. Sorry, I didn't realize I've gone over time, but very happy to take questions. Thanks.
Thank you, Dr. Hall. So questions from the floor or online?
Hi, I know that I've heard of some issues with people starting to get vaccines post-transplant and such, especially with public health units kind of not giving them anymore. I was just wondering what you guys are doing, especially if family doctors aren't kind of on board with helping with that at times. If you've had any luck with other agencies or anything like that.
Yeah, I think this is becoming an increasingly difficult problem, and as the population grows and there really are more and more the encountered situation where they simply don't have a family doctor, I think that makes it really challenging. I can't say that we have a specific solution, but we are looking into whether we bring this back to the hospital level. So back in Melbourne, I was part of a revaccination clinic in the hospital that was really fantastic. We saw every autologous and CAR T-cell patient, and they got all of their vaccines on time. It was all recorded in Epic, which was the computer program we use. So all the timing was there and available for all clinicians. So, I mean, yeah, it's a difficult kind of solution, isn't it? But maybe this is something that we need to start looking towards. So prioritizing their pre-transplant, transplant, but also post-transplant care should really be as prioritized as the other components.
Thank you. Dr. Lam?
I'm wondering if you can comment on, in terms of non-Hodgkin lymphoma patients who are not being treated or have had prior exposure to anti-CD20, like rituximab and whatnot. We get a lot of questions about live vaccine. And is there a population that you would say immunocompetent enough, even for ones without any prior treatment, to undergo live vaccines?
Yeah. So I think if they haven't had any active treatment, I'd still be incredibly cautious. I have seen a CLL patient that was on the watch and wait, and they actually died from Zostavax. Yeah, so I would particularly avoid that kind of patient. In the non-Hodgkin's lymphoma patients who we truly believe are in remission, I'd be very conservative with anti-CD20 therapy. We know that the biological half-life is much longer than what we kind of initially thought. So in the range of 12 to 24 months, maybe this is the patient that I would do a CD20 B cell count in. And then again, really thinking about it in terms of risk benefits. So do they actually need the live virus vaccine? What is their serostatus? What's their risk of exposure? And then if you think that, yeah, it's safe, then counseling, I guess, about even the risks of developing vaccine-related disease with the patient and kind of making a shared decision about that.
Any other questions? So often in clinic, we encounter patients who inquire about the RSV vaccine, and it's not covered. Yeah. And so it does come with a cost to patients. And sometimes these patients are undergoing active therapy, such as B-cell depleting therapy, and may not respond. And so any kind of comments with regards to guidance for treaters in terms of how to approach such a case?
Yeah. Yeah, I think it's, I guess, a real pity at the moment that it's not covered. So I think for these patients, what we're doing with the solid organ transplant recipients is, if we're seeing them in the pre-transplant setting, can you try and get the vaccine in then where where they're going to actually respond. I think if they are on active therapy and you think that there's going to be severely impaired, I guess, humoral immunogenicity, it's a discussion with them openly that there probably is still some cellular immunity benefit. We saw that in the COVID-19 vaccine literature in B-cell deplete patients. Some of our studies, we found kind of robust T-cell responses that were similar to the healthy controls that we analyze. So there potentially is still a benefit for them. But I guess it's still so new as well. We really don't have any data in immunocompromised patients yet. So this is something that I guess we have to continually assess.
Because such a conundrum, you're trying to protect them when you're most vulnerable,
Yeah.
and at the same time, they're the least likely to respond. But I take your point in cellular response.
Yeah.
Any other questions from our online audience? Yep. I had a patient who was given Shingrix at post-transplant schedule and did develop a V1 zoster within 1 week. Was this coincidence?
Yeah, I think this is coming up more and more. I think my question back to them would be, were they still on prophylaxis? So we are seeing these kind of paradoxical reactivations after Shingrix. And so that's why we kind of are continuing prophylaxis for a month after the second dose. It also allows them time to actually be protected. It's, thought to be at least 4 weeks. So you're kind of bridging them to that kind of expected immune response.
Thank you. Thank you, Dr. Hall.
Thank you.
Okay, and so now, there are a few more slides. I'll just flash through them. So some availability and costs here. Any family doctors want to comment on this? How accessible is it when trying to fit in vaccine schedules in your practice and even securing these vaccines? Because I don't think it's straightforward or easy. I find that it's often tricky and patients are often coming back asking for help, and we're not doing this enough in-house to know. Do you want to comment, Elena?
So thank God the Prevnar 20 is now covered, right? And Prevnar 15 as well. And that was actually a question that I wanted to ask. So in pediatric population, post-transplant, I would imagine we're thinking a Prevnar 15, not 13, right?
Replaced by 20,
How about pediatrics? Pediatrics. For pediatrics, right? So post-transplant, I wanted to ask that question. No. So post-transplant, you're talking about Prevnar 13. Okay.
So PCV20 is recommended for adults. Yeah, this is the gold standard, but it is pretty new. So if it's not available, then still following the PCV13 and giving the PPSV 23 at the 12-month mark is, I would say at the moment, an acceptable alternative.
And
for peds?
In peds, basically, I have noticed that 2 of the cancer patients that I've looked after and monitored have all been given the vaccines through the cancer center itself. So that's all the information that I have.
right, because now they replaced the Prevnar 13 in pediatrics with the 15. So that's why I was wondering.
And for adults, they need the 4th dose. It's replaced by C20, and for adults, they need the 4th dose. Before, they needed only the 4th dose if only they had GVHD.